Hello, my name is Paul Naji. I'm an associate professor at Johns Hopkins University, and I lead our efforts here at Johns Hopkins to convert our EPIC EHR data into the OMOP Common Data Model. And so today I'm going to be talking about how some tips on how we build it and how ways that we can maintain it to keep it fresh, improve the data quality, and to make it maintainable and sustainable. And so I have laid out my main tips and suggestions for other health systems that are trying to take advantage of Odyssey because it can serve multiple needs in that making sure that you know what your goal is. It can be used for external clinical registries. It can be used internally. It can be used for building a learning health system. And so trying to understand what your goal is for converting your EPIC data or your Cerner or whatever your EHR is into a common data model is really important so that you have both the leadership buy-in, you set the right expectations, and you've got the right metrics for maintaining success for your project. I'm going to talk about some staffing requirements that we've seen across the field for some of the types of roles it's useful to have to help maintain a state-of-the-art data set around your EHR data, making sure it's secure and enabling its availability for researchers as well as for external registries. And then I'm going to talk about some ways to not reinvent the wheel. This has been done over 100 times at least in the US, in other academic medical centers. So there's no reason for you for doing this from scratch. And also some of the benefits for joining a clinical registry for not just potential fundings to sustain the efforts, but also because it provides a very clear stake in the ground for the data specification that needs to be delivered to that registry is really a nice way of setting some milestones for seeing if your data is in the right format that you're looking for. And then also I want to talk about a little bit about some of the data management systems that we've seen that are very useful for managing your ETL process and to really make sure that you've got change management and that you've got good monitoring over it. And then I wanted to talk a little bit about some of the Odyssey software tools. When most people think of OMOP, they think of a data model, but along with OMOP comes with over 6 million lines of software, 250 different tools that have been written that can really help you improve the data quality, visualize your data, analyze your data, as well as even perform time at risk analysis if you wanted to conduct research with your data. And then I want to talk about some of the ways that we've simplified the deployment of the Odyssey tool stack to help support a lower cost of ownership and get the most value. At the end of the day, I want you to get the most value out of your OMOP data set, find the most users that can extract value from that data, and it'll help you advance your goals in supporting clinical research for our field and within your own community. And so lastly, want to talk about, we have an Odyssey data partner network. And with that partner network, you can get benchmarking on your data. You can look for other ways other groups have enriched their data for particular clinical registries, as well as getting feedback on potential areas that you might want to improve your data. All right, so let's first talk about what is your goal. And I feel like there's really are like 3 different goals. And the first goal, and often a lot of sites get involved with OMOP because they are funded to support a clinical registry. And we're seeing there's actually thousands of clinical registries. They've sprung up from a lot of national societies and lots of diseases, and they really help advance the field. However, a lot of them are using bespoke data models or custom data models that really aren't that have to require an immense amount of mapping from the health system. And these have become really hard to manage from the health system's perspective. And so what we've seen is a centralization for a lot of clinical registries to move to a common data model like OMOP. OMOP has been the most popular one in terms of it has been behind the NIH's All of Us registry, as well as the M3C. The FDA has been using it for drug repurposing. The CDC has been using it for clinical surveillance, as well as, of course, the NIH has used it as part of initiatives for helping with building research communities. And so I think external, delivering this just means converting your proprietary EHR data into a common data model and then being able to deliver it to a external clinical registry. This means you don't really have any internal users of this data other than the need to deliver it for different purposes for external users. And it's been useful in that we've seen a lot more centralization. This can be a lot of work. And so having, being able to centralize to one common data model for all your external registries can reduce an enormous amount of FTE costs in transforming the data for each different clinical registry. But that's just kind of where you want to enter the game. I feel like there's a lot of value for health systems to actually use their data and to support their own researchers. And so to supporting the research mission within their health systems, this means that they could actually be part of the Odyssey Data Network, where their researchers can then use their OMOP data internally to help build and validate their phenotypes for the diseases they want to research, but then they can take that research across the entire data network, which includes over 500 data partners representing over 960 million unique patients. This is really how we can scale clinical evidence from observational data. And this is really an exciting, really a key part of advancing clinical research and creating evidence at scale, is building it outside of your evidence within your institution. That's because there's lots of bias around observational data, and in particular tied to different types of health systems in different areas. And there's always different dimensions where it's constrained, where it's really beneficial to combining with different data sites to get a more holistic view of a patient population. So I think the second one really is supporting research. And then for those who are really trying to push forward, that they really are, and I see this is where there's a higher investment, is they really are trying to embrace being a learning health system. And that means helping their physicians research their patients, helping them use their clinic as a laboratory, helping them understand their patients, helping them when they have a hunch that a patient responding differently to a treatment and maybe a new subset of a disease. And this is really exciting, where OMOP can be used for both helping them generate evidence and for studying their patients and for scaling that evidence across the network, but then also turning evidence into practice with clinical decision support applications based on this evidence. So we feel like this is really, we've seen several health systems now embracing OMOP internally, building out multiple clinical registries inside the health system for different diseases, for different clinics. And this has been an exciting process. So I'll try to put some hard numbers around these. And so I'm going to put some stakes in the sand that generally, if you are looking to do a relatively low resource, you probably can support your OMOP instance for about a half an FTE. And this is for external clinical registries. It doesn't take a ton more to support your clinical research mission if you wanted to also use that OMOP data for other purposes. And then if you really wanted to deploy all the tools, and if you wanted to get a full value of enriching your OMOP data to support your clinical institution, I would say up to about 2.5 FTEs to really support that. Now, these are really different roles. We found that to help support a implementation of OMOP as from EHR data, obviously we would want to have a program manager. A lot of the work would rely on a data analyst that could do the transformation of data from relational data models within the EHR, or from even potentially from FHIR messages into the OMOP data model. And this is basically transforming data into concepts and then transforming the data into the format of the Odyssey OMOP data model. And so it's a lot of SQL. It's usually about 60 or 70 different scripts to go from inpatient and outpatient across medications, labs, procedures, and diagnosis codes. But then on top of that, this ends up becoming, it's useful to have a data platform. You can do this with on-premise SQL Server, but you're going to need to have a relational database to do this with. We've seen more modern implementations are now using cloud platforms, and they're using different types of analytics platforms. Here at Johns Hopkins, we use Databricks as our data engineering platform, and it's been very useful for doing distributed and for doing parallel processing and for really doing things at scale. We have about 2.5 million patients that are part of our data set over the past 8 years that represent over 1 billion observations on those patients. And so we use a secure environment here at Johns Hopkins with Microsoft on the Azure cloud. And then we use Databricks as the data transformation component that does the data quality assessment as well. And then, so a data engineer is very useful to understand how to take advantage of modern data architectures. as well as a clinical informaticist. A clinical informaticist is someone who can take custom local codes that might not be mapped to a clinical terminology like SNOMED, LOINC, ICD-9 or 10, or CPT codes, and be able to really help you find out try to map that into a terminology space. Everything in OMOP is a concept that's generally tied to standards. And so this is something where it's really important to have an informaticist that can infer from understanding the source data. Much of Epic data doesn't have a lot of data provenance of what the data means, how it's collected, and really how it can be tied to a standard. And so this is the role of an informaticist to help with that mapping and validation, as well as having IT system support to be able to deploy the tools that can really accelerate your ETL process, like tools like Usagi that can be used to do concept mapping across all the different vocabularies within Odyssey. Right now, Odyssey has over 154 vocabularies that it maps to, and so with over 6 million concepts. And so having text similarity searching across those semantic databases is really important to be able to help you map your data. But as well as that, there's actually really powerful data science platforms like Atlas that can help you visualize your data, that can help you to create new phenotypes for defining populations of patients and cohorts, whether it's a target, an outcome, or a control, as well as Hades, which is a large library of R methods that have been validated for performing time at risk analysis. Okay, so generally, I find you often don't need a full FTE for any of these roles, but you do need to have the expertise from someone on that team. So it's useful to have a distributed group with some buy-in from your enterprise IT, as well as making this an enterprise project that can serve both chronic diseases as well as acute diseases that are seen in the ICU. And so this is actually should be seen as a resource that can be used throughout your clinical research enterprise across your medical system. Okay, so I think other key invention tool here is don't reinvent the wheel. And that is, there's actually a lot of great sources. So a lot of the ETL, I would say that, most EHRs are going to have about at least, there's definitely customization when you build out a flow sheet, when you build out a nursing unit, builds out their workflow, but and you'll see all kinds of different surveys that we use for patients, and we'll do a lot of customization around that. But at the heart of an EHR, it's often about 60 to 70% the same. And so you can really get started really far out of the gate using existing transformation templates. And these are basically SQL codes that have been built that are meant for sharing. And I really think one of the most heavily developed one was one by Roger Carlson from Prisma, who's shared on the Epic User Web, which is coming from the Clarity relational database from Epic, and it transforms that into OMOP. More recently, Dwayne Willett, the CMIO at UT Southwestern, has developed an incremental loading methodology off of the Caboodle package, which is a step removed from the Clarity as a data modeling environment, as well as there's many sites that have implemented Cerner. But if you look within the Odyssey community, it's not hard to find different sites that have been able to implement your EHR, and being able to partner with them is really useful. That really helps you avoid a lot of the potholes in going through the ETL process and being able to assess where to get started and understand when to know when you're done. Okay, so there's lots of education within the Odyssey community. It has a great place to start is the Book of Odyssey. There's a whole chapter on the ETL process, on how to first start with patients and then have an honest broker table, how to then start with visits before you start bringing in clinical data, and then all the conventions that we use within the Odyssey community. So I find this is really a great place to start, but there's just a ton of great resources available right now for Odyssey, such as the actual GitHub repo for the common data model comes with lots of documentation, as well as the entity relationship diagram of the data model. That is an incredibly useful resource to be used while you're doing your ETL to make sure that you're mapping it into the right field data types that you're putting in. And there's even a lot of discussion, if you look into the tables, what they're trying to achieve in that data so you can understand the context of the transformations. And then more recently, we've developed something called Themis, which is a knowledge base of conventions. This is in addition to the data model. These are basically how to answer certain types of questions for how do we link mothers with their children, how do we map different types of device data, how this really is a great tool for trying to do things in a common way. The goal here is the more that we adhere to conventions across multiple health systems, the more value we'll have in being able to do scalable network research as a community. So this is a really valuable resource to take a look at and learn about best practices. We also have the Odyssey forums is a large forum for asking questions and answering them. So the first place to go if you have a question is to see if someone else has asked it before. And then also we have something called the Eden Academy, which is a large learning management system where there's actually many self-based courses that you can take. This platform is for free. It was developed by the European Health Data Evidence Network. It has 22 courses in it that have been taken, that thousands of people have taken. And the one that I would highly recommend is the ETL course, because that one actually walks you through the vocabularies and how to go through the ETL process. And it includes several videos as well as some knowledge assessments to make sure that you're able to you're learning the material. And lastly, there is over 600 videos on YouTube. There are lots of great ETL videos on how to go through the process with different types of databases, with different data platforms. There's whole working groups within Odyssey for groups like Databricks and working on working with different types of data as well. So I highly recommend taking a look at YouTube. And you'll see that you'll see a lot of most of the Odyssey material ends up on YouTube because we are an open science community. So we like to create public artifacts or manuscripts that go into PubMed, videos that go into YouTube. Our software goes into GitHub. And so this is something that we really cherish as an open science community, was to do things in a transparent process. So that hopefully will make your life a little bit easier. We also have a working group. This is the Healthcare Systems Interest Group that's led by Melanie Filosky. And this working group is to establish a repository and to help sites that are going through the ETL process, to help them with that journey, helping them get as much value as they can, help them understand how to take advantage of OMOP and learn from others on how to do things. I've found a great value with this, and it's really great to learn. I often find we end up sharing some ETL scripts between our sites to help us enrich our data. Okay, so there's lots of things to do with the Odyssey community, but there's also really many clinical external registries that have embraced Odyssey as a common data model. And this is actually really a valuable thing to do. And I've seen value here at Hopkins with this. And the truth is, you probably already belong to several, and really just want to look to where in your organization you have lots of people that are doing chart abstraction, because really there's just so many different registries in the US right now, and look for ways that we can help automate that transformation so we can reduce the chart abstraction burden. And so today, there are more and more registries that have moved over to OMOP, and it really can defray the cost of supporting an OMOP data set for your organization. The other things I really like about it is a registry is really comes with a clear data specification. Well, one of the registries is from the American Society of Hematology, looking at sickle cell patients, and they come with a data specification document of what data they're expecting to see, what concepts they're hoping to see, and really, so it's a great way of saying this is the data we'd like to have in this format. And so it's a great way to start your Odyssey journey, knowing when you can be qualified for that registry. There is actually no end to enriching your data. We always want to continue to enrich our data. There are many variables within an EHR. A lot of them are not mapped to any clinical standard. And so we have a term about trying to avoid going down the rabbit hole and only mapping concepts within an EHR that are going to be potentially valuable for helping you to do clinical research. And so registries are a great way of data specifications. I also found that they're very helpful in providing technical support and feedback during the ETL process to help you understand your data quality, how you're managing your units on your lab values. And so I found them to be very beneficial in giving you technical support to help you enrich your own data for all of your OMOP data sets, not just for that one clinical registry. And most of these clinical registries are going to be just a simple subset of the patients within all of the patients within your EHR. And so it's pretty easy to make a subset of your patients and then have all of your patients benefit from these improved data quality processes. And so there's been studies now showing that Odyssey is highly effective to facilitate efficient collaboration between researchers for federated data networks. This is a growing field, but it's really exciting to see a common data model across health systems and being able to really accelerate the time we can do to conduct an observational research trial. I also recommend highly looking at data operations management platforms. And these are basically, well, you end up with like 60 or 70 SQL scripts that are going to transform data from your EHR into the OMOP data model. And so this is going to be running either monthly or quarterly, or in some cases it's run near real time as an incremental loading process. But so having a system that actually manages the transformation and helps you see if you should be getting more patients this month than last month, that the data hasn't shifted on you, that you have data quality checks in place. Some monitoring is actually really very useful. And this also makes sure that all the scripts ran correctly and that they didn't default into an error. And so I've seen we actually have working groups within the Odyssey community around Databricks and around dbt. Databricks is a commercial vendor where dbt and Apache Airflow are actually open source solutions. But I feel like these are great tools to help you, because you're going to be doing this transformation on a regular basis. Having a process that can help you manage it is a great way because you want to constantly, as you have more patients, you're going to be updating your data set. And this is a great way of maintaining a lower cost of ownership for that data. So the other big thing is taking advantage of all the Odyssey tools. And some of the big tools that really can help you when you're ETLing are the Atlas tool with the Achilles package in it. And what that tool does will help you provide you some visualizations on your data. It'll give you the time trending for how the data is being entered into your database, and it'll give you a way of visually looking for outliers, which is really a powerful tool. And then along with that comes the data quality dashboard. One of my favorite things about OMOP is how serious they take data quality. We run out of the box over 3,000 data quality tests, looking for completeness tests of data, looking for conformance of whether an element was in an appropriate range, as well as plausibility tests. That would be things like, did the start date begin after your end date, or your admissions happen after your discharges, or sometimes they're temporal, sometimes they're looking at non-temporal components. So did you have a higher threshold of patients or female patients that have had a prostate exam? And so this would be, usually we have like a threshold of a few percent because these things can happen, but generally they're not very frequent in their occurrence. So these are two really powerful tools, and I highly recommend them in terms of help you validating your data, because you'll end up having a lot of patients and a lot of for a certain period of range, and they can have and having these types of tests are very useful. What you'll find is that if you fail a test in the data quality dashboard, you can actually just click on it and it'll give you the SQL code that it ran. So then you could just take that code and run it natively within your environment to quickly find out why you're getting that error, whether you didn't map those fields correctly, or didn't apply the units correctly, or some other reason for that. But I find it to be very useful for just grabbing the SQL code for where it thinks there might be an issue. Sometimes they're not big issues. Like sometimes you might not be populating your data set with cost data, and so it'll throw those flags, but that's not something you really need to worry about. And so, or specimen data is the same way. But I find that overall, most of the tests are very useful in helping you get some assessment to whether there's some sort of systematic issue with your ETL. And I find this is really useful for the first time you do it as a quality assurance component, but it's also actually useful to do it every time you do a transformation to make sure there wasn't significant data drift. We find that the EHRs have proprietary data models and they are subject to change. And so it's very useful to keep running these DQD tests every time you do the transformation to make sure that you're not seeing a substantial shift in how things are calculated within the EHR. So the next one I had was so broadly. So what we've done within the Odyssey community is we've packaged a lot of the software together into one Docker, a series of Docker containers that we call Broadsea that can be deployed very easily within a few minutes on a Docker environment, and that would host both Atlas and the Web API and Aries and RStudio and Achilles. And this allows you to have an environment to be able to actually visualize that data without having to do setting up those servers independently. So this is a nice way of standardizing our software distribution. These Docker containers are also hosted within Azure and with Amazon and Google. And the cloud providers also provide security scanning, which helps us maintain security within our dependency trees. So the last thing I wanted to talk about is the Odyssey Data Network. The Odyssey Data Network is a volunteer data network where sites will get benchmarking of your data compared to other similar sites. This is across the entire Odyssey community, including Eden and Europe, as well as Southeast Asia. So this covers all of our continents. And this is where we want to be able to provide you benchmarking of what your data looks like and in which ways you've enriched your data, and also helping you learn from other data partners on how they enrich their data, how they manage their data quality, and how they can, and hopefully giving you feedback on how you can make small alterations to your data to make it fit for use for different research purposes, for being able to be part of different clinical trials or clinical registries. And this also will help you be alerted for new funding opportunities for those data partners. So this is where it's great to build a group of folks together to go after a U grant and to help you with your researchers going after grant funding opportunities. Here's a ready-made network of sites that already have a base of most of what you need within the main data components, but often need to add on an additional data collection layer around a specialty or a disease. Excellent. Thank you so much for your time, and I look forward to hearing any questions.